Hello, we're going to talk today about male factor in infertility. My name is Alejandro Aparicio. I'm urologist. I work in infertility since at least 10 years in many centers in Bogota, Colombia. So first, we have many questions. There's a real male factor. This male factor has a cause. It's treatable, and it will affect the newborns if we do some IVF or some procedure. And the most important question is related to a worse disease. First, we have to identify what's the male factor. The problem is that we don't have a clear cause in at least 25% of the patients. Usually, when we find a defect in the form of the sperm, we really don't know the cause, and it's usually idiopathic. So many times you just want to try to optimize the seminal parameters, trying to help the couple to get pregnant. When we study a patient with infertility, we have to search for the medical history. There's some exposure to any occupational risk, like some toxics, like herbicides or different poisons or toxic environments. Did the patient smoke? We really know that the smoking is a factor that increases the damage of the sperm. There's history of infertility. The patient have any history or symptoms in the sexual performance, and we have to search and evaluate the testicle. So we have many tools like the physical exam, the Doppler ultrasound, the spermogram, that is the most important test that we can perform in a patient with infertility, and the last, the hormonal study. And we really know that the man should always be evaluated. We have to rule out systemic pathologies like cardiovascular disease, hypertension, diabetes, hyperlipidemia, prostate cancer, testicular cancer, because we know that infertility sometimes show us these diseases at the beginning of the disease. And we know that sometimes there are increased risk of some diseases when we are seeing a patient with infertility. When we look for the medical and reproductive history, we have to identify risk factors, behavior, and exposures. The lifestyle of the patient, there's a family history of infertility, their comorbidities, diabetes, obesity, testicular cancer, infections, or surgeries in the genitourinary tract. It's important to ask for the patient and the couple about sexual habits, how frequently they have sexual relations. They have good erections, the erections allow penetration, they're satisfied with the sex. In the ejaculation, they have pain, they have blood. It's important to understand the whole sexual habits of the patient. And here we have the first point. Sometimes the partner and the couples don't get pregnant because they don't have frequently sexual intercourses. And there's many believers that think that there's a problem with the semen because it deteriorates or it change if the patient don't have enough sex. And we know that more than 5 days that the semen stays in the testicle, it begins to deteriorate. Usually the people think that you have to wait at least 2 days to recharge the testicles, because if you have a lot of ejaculation, the semen will decrease in quantity and in characteristics. But we know that normal men with daily ejaculation remain and with normal sperm samples. And usually patients with oligospermic samples improve with daily ejaculation. So it's important to ejaculate really often. And we know that if the patient and his couple have frequently ejaculations, the rate of pregnancy is much higher. So we know that if the couple have intercourse every day, they have a chance of a fertility of 37%. If they have intercourses every other day, is 30%. And if they only have one per week, it's just the 15%. But we know that daily intercourse produce and induce stress in the couple because the couple feel that it's like an obligation to have intercourses every day. So this stress is not healthy for the couple. And it's common to see that many of the couples that search for fertility advice have less intercourses that we really need. When we search for the physical exam of the patient, we have to look for the penis and evaluate the presence of hypospadias. Hypospadias is an anomalous insertion of the urethra that are not in the tip of the penis, but in the middle of the shaft or lower. When the patient ejaculates, the semen don't get into the top of the vagina, and it's impossible or it's difficult to get pregnant with the semen in the wrong side. And we have to search for the testicle and touch it and understand and search for consistency because a hard testicle sometimes is like tumor, or really soft testicle is a abnormal testicle. We have to touch the epididymitis because the epididymitis is important because if it's hard or it's painful, we can talk about infections or obstructions. And we have to search for the vas deferens. We already know that there are many diseases that can cause vas deferens agenesis, especially the cystic fibrosis, and it's important to search for the vas deferens. We have to touch for varicocele, it's an important find, and look for the secondary characteristics of the patient. And here is important the importance of the testicle, because the size of the testicle talks about the production of sperm. We can see here in this table that smaller testicles have less sperm count than the bigger one. So we have to touch and size the sperm with this orchidometer. And it's important because if we find a small testicle, we already know that the testicle is not producing enough sperm. And the varicocele is something we find in the physical exam. These are dilated veins of the testicle, and sometimes they have to be corrected to increase the characteristics of the sperm. And we really know that varicocele is a problem when we find the varicocele and it's palpable. We know that the patient have problems with fertility. We have a normal female partner with a treatable pathology, and they don't have to get pregnant right now, because when we treat the varicocele, we have to wait at least 6 months to see changes in the sperm. So at the beginning, the sperm is still in bad shape, so we have to wait. We have to search if the patient have abnormal seminal parameters, but usually the correction of the varicocele is not indicated in an isolated teratospermia with a normal spermogram, or if it's subclinical. We just have to correct it if really we know that there's a problem with the sperm and the patient wants to get pregnant with his wife, with his partner, and if they have time to get pregnant. And the spermogram is the main study of infertility. It's important that we have to perform at least 2 studies if the first one is abnormal, because just one study sometimes is not representative of the ejaculation of the patient. We have to try to advise to the patient that have 2 or 7 days of abstinence, and in fertile patient we have to wait just one day. And here it's really important to have an fertility center who perform the test in the right direction. And if you don't know the place that when they perform the sperm, you have to send the patient to your favorite or your preferred fertility center to be sure that the sample is adequate and the lecture of the study is okay. And here are the normal parameters of the sperm, extracted from the World Health Organization study in 2010. They searched for a lot of men in different countries, and they found the patient that can conceive in 12 months, and they report the 5 percentile of the patient. So usually the semen volume usually is 1.5 milliliters. The total sperm number is 39 millions. We try to use not the total sperm but the concentration, and the concentration have to be at least 15 millions in milliliter. So this is the magic number. The total motility is at least 40%, and progressive 32. The vitality is 58%, and the morphology, the percentage of normal forms is at least the 4%. So with the spermogram, we can classify the patient in oligospermia if it's less than 15 millions, astenospermia if they have less than 32% of progressive mobile sperm, teratospermia if it's less than 4% normal forms, or combination oligostenospermia, oligoteratospermia, astenospermia of the mix of 3 of them, oligoteratospermia. When we search for the seminal analysis and we find low volume, sometimes there's incomplete collection. We have to advise the patient the right way to collect the sample. Sometimes they have problems with hormones and they have androgenic deficiency. Sometimes you can find obstruction of ejaculatory ducts, but it's not so common. Also, absence of vas deferens or retrograde ejaculation. When the patient ejaculates, the semen goes to the bladder. In the counting, there's a biological variability of concentration. That's why we have to at least have two samples, different samples. And the lower limit is 15 millions in the World Health Organization study. And we know that positive predictive value for fertility reaches 40 or 55 millions. Above these levels, it doesn't increase the pregnancy. So 15 to 55 is okay. And one of the problems with the semen samples, if you see a lot of patients with infertility, is when the semen start to change. There's many patients that have normal sperm 10 years ago, and in the next years, the sperm start to decrease, and it's a problem that was worse every day. And if you just wait, you are losing the opportunity of freeze the best sample that you can get in this month. Because sometimes the production of sperm in the testicle decline, one day they stop. So if you find a patient who is declining in his production and is getting worse and worse, don't think so much. Freeze a sample, have a safe sample, freeze it, and after that you can study the patient with calm and do the surgery for the varicocele or give some medication or whatever. But you have just a sample safe to use if they get worse with the time, because sometimes we can change the future of that testicle, and with the time the testicle get worse and worse and worse, and there's no way to go back. When we look for the mobility, is really complicated to classify, and we really know that at least we need 32% of motile sperm. Right now, we know that there's a lot of more types of motility in the sperm, but the most common are A, B, C, and D. A is fast progressive mobile. D is slow progressive mobile. This is the two main most important type of mobility, and we at least need 32% of the sperm with this kind of motility. And C and D are non-progressive and motionless. I really know that the mobility is important for the penetration to the zona pellucida. So it's not important if you are going to perform IVF. Usually, low motility is associated with mitochondrial problems and flagellum structure, and is altered by increased oxidation in seminal plasma, age, and radiation. And there's many things that increase the oxidation of the seminal plasma, especially the smoking, especially be exposed to external agents and varicocele. And what about morphology? This is one of the main problems of the classification in the World Health Organization study, because we are really strict with the classification. It requires a lot of training, and usually, at least we need 4% of normality. So I think we are really strict with that. Just 4% of the sperm is normal in this classification, but it's an important predictor of in vivo fertility in this kind of patients. So we have to check this. Sometimes the patient are worried because just 4% is normal. What about the 98, 95% of the rest of the patient, of the rest of the sperm? And sometimes they ask if they have an ugly sperm, they're gonna have an ugly baby, and we need to explain to the patients that this is just a classification. It's not is going to impact in the pregnancy in the future. And we really know that the morphology less than 4% is not associated with fever pregnancies in insemination, and is not an isolated criterion for IVF. You just find that the alteration in morphology, you can go to an insemination and you don't need just for that perform an IVF. And one of the most interesting topics of the assessing the human sperm is the DNA of the sperm, and we have a lot of ways to check the integrity of the DNA, but one of the most used right now is the chromatin integrity of the or DNA damage in looking for fragmentation of DNA. Usually the fragmentation of the DNA happen during the intratesticular spermatogenesis, during the maturation of the sperm, and in the semen transfer. And it's more common that we find damage in subfertile patients. So high fragmentation of the DNA is associated with poor pregnancy rates, embryonic death, poor embryo development, and poor implantation. And usually it's still associated with radicals of oxygen and with varicocele. So we see the DNA intact in the sperm right here. And here there's a picture of fragmented DNA. The DNA is all around, or is not intact like this. And usually we can do this test in many type of patients. There's a lot of difference in the way that we search for this. So the problem with this test is that it's not really standardized, but they can help us a lot if we are looking trying to understand why there's unexplained fertility, recurrent losses, and it's a predictor for after a failed assisted reproduction techniques. Some authors are advising this in elderly men going to reproductive techniques, trying to select the right time to do it. And so usually, if we find a patient with alteration in the um, in the DNA, and we manage the problem with varicocelectomy, antibiotic therapy, or treatment for chlamydia mycoplasma, we can review the success of this treatment doing a second test. Sometimes when you freeze the semen and you want to know the semen is it's okay for an IVF, you can do this. And patients with febrile episodes in the last months. So here we can see one of the techniques to search for DNA fragmentation is the tunnel test. So here in the tunnel they put fluorescence in the DNA who is fragmented. This is the fluorescence that we see here is just two sperms with a normal fertile man, and here is a lot of fragmented sperm, DNA sperm in an idiopathic patient with idiopathic infertility. So there is every day we're more aware about this, and we're trying to do this more often than in infertility patients. And when we perform hormonal studies, we have to evaluate only if there's an alteration in the spermogram or if the patient have symptoms of hypogonadism. The first one is FSH. The FSH is suggests when it's elevated an alteration in sperm production. And usually when we have absence of spermatogonias is high. In arrested maturation is one of the types of found of things that we find in a biopsy, and there's just arrested maturation, maybe normal. That is a problem with, because not always that we find FSH normal, we are sure that we are going to find sperm in the biopsies. And arrested maturation usually is normal, but we can't find a normal sperm to use to IVF. So not always is a predictor of adequate production. So with the FSH, we can try to understand how it's working the testicle, but we are not sure. But usually high FSH does not indicate complete absence of sperm in the testicle. So usually when we have a high FSH, we can perform the TC or micro TC searching for sperm. Usually the other test that we perform is the total testosterone, and they talks about the testicular function, and it's elevated. We are thinking that the testicle is in failure. Estradiol usually is used when we want to manipulate the testicle, if they have an alteration in the testosterone and estradiol ratio. Thank you very much.